Thanks, Vish. So our next speaker is Dr. Reza Ashrafi. He's a consultant adult congenital cardiologist at Liverpool, and he's got an interest in.
Thanks, everyone. So just a bit about palpitations in pregnancy. Forgive me if pitched too low, too high, not right in any way. So just a little summary of what we'll talk about today. I think this is now a few years out of date, but the general trend is correct that all the arrhythmia rates are going up, and regardless of your arrhythmia, this seems to be bad for you from a general complication or mortality rate in pregnancy. See that probably the trend in some of the newer data is more significant for older mothers as well. It's the most common cardiac complication we see for someone with a known condition. So why is this? One of the major reasons is a volume reason. In particular, your atria very, very volume stretch receptive, particularly from an arrhythmia perspective. And that women start from a slightly different place electrically from men in terms of their ion channel function. So you have an area of the heart that's particularly volume sensitive for someone who's starting from slightly different spots electrically. And then you've got the hormonal effects of pregnancy. And if, we've already heard the cardiologists can't agree on anything, basic scientists cannot agree on anything, and every animal model has a different opinion about what estrogen and progesterone do to various ion channels. But I think we have a touch of consensus that, your QTC, is going, down towards the end of or through pregnancy before rebounding up postpartum. Due, we think, largely to the protective sort of QT shortening effect of progesterone. So there's a whole sequence of events in pregnancy that you can understand why it might lead to arrhythmia burden a little bit more. So fractionally there, you can see that probably it's just the relationship of estrogen and progesterone and how that sort of ratio varies is probably doing it. And then we can see that estrogen will affect some of these ion channels, which may make you more pro-arrhythmic. So, I think in terms of the clinical history, there's a lot to think about. Most of them give a very good description that you can make the majority of your decision on without doing anything, just from what they tell you. I think if a woman's had arrhythmia problems prior to pregnancy, that 50% or more, it'll get worse in pregnancy. So if they've had a history of SVTs, AF something, we would, if we see them for preconception counselling, we would counsel them that you can expect that to get worse. You can expect it to get worse in terms of frequency, you can expect it to get worse in terms of how you cope with the arrhythmia. If you're 34 weeks pregnant with a huge increase in your volume weight, it's not going to feel, as good, or I should say less bad compared to pre-pregnancy. So we have a little think about what they had before pregnancy. How worried am I, depending on the description of things? Well, if they've got an associated syndrome, if they've got wrong QT, then arrhythmogenic ventricular cardiomyopathy, and they're telling me that they've got long runs of palpitations, then you're worried your level of investigation is going to go up. Is there a family history of things, somebody suddenly dropped in at 35, 40, these things? These all add to how much you're thinking about investigating, how much you're worrying about that woman. Have they been on a drug that's worked before and they've gone to see the SHO in clinic who's told them to stop that drug immediately? Incorrectly, normally. Have they had a procedure before? Have they had an ablation before? Have we done something? Has something worked? Has something not worked? What did the cardiologist find at the EP study? These are all things which will help you decide how much more do I need to do? How worried am I about this woman? And where do we go from there? So, in terms of descriptions that we are not worried about, painful thuds, feels like I miss a beat, then I have a really painful one, a big one. That's a classic description of ventricular ectopy. Because what you never feel is the ectopic itself. After the ectopic, there's always a longer period of filling. So the next beat has a larger volume, so that's why it feels painful or like a bigger beat. So this, in of its own, I have a few of these, not worried. Everybody in the room has ectopy. Just how much people notice it varies person to person. So that, not worried. Things that get better with exercise. Again, you can suppress most ectopy with exercise in non-worrying conditions. So if they say, I had a few extra beats, a few thuds, but then I went for a jog, whatever, it all went away. That would worry me less, because that would be less worrying ectopics. Don't notice if I'm busy. Again, very unlikely to be a significant arrhythmia. So that's mainly the ectopic story and what we're not worried about from a clinical history perspective, assuming that they don't have a family history of ARVC and somebody dying in their 30s. Other things, when people say I have a couple of seconds of flutter, again, not worried. Everybody is getting ectopy. If you do Holter monitors for everyone is getting short runs of things. So a couple of seconds, not worried. More aware when I'm tired, stressed, again, not worried. When I'm lying in bed at night, I can hear my heartbeat, not worried. These things are all common, very, very rarely pathological. Another thing for people with ablations, one of the classic descriptions people give, palpitations, non-worrying palpitations post-ablation, is they say, I feel like I'm getting a flutter and it's going to stop like it did, but it doesn't. And that's because where we ablate, especially in SVTs, we can't ablate the atrial ectopics. But what we can ablate is the bit the atrial ectopic is going to go down. So they feel the flutters, but because we burn the pathway, you don't get the sustained arrhythmia. So when we ablate people, we often will say, look, I can stop the SVT. That doesn't mean you will get no palpitations ever again. You still might get the flutter here and there. It just won't go anywhere. So this description, post-ablation, not worried. Things that do worry you in the story: dizziness, syncope, anything with a hemodynamic effect worries you. Because I think that tells you something about the significance of that arrhythmia. It may not be a life-threatening arrhythmia, but obviously that is having a hemodynamic effect, and probably we need to know what it is to decide what to do. Irregular, because we're more right, it's going to be atrial fibrillation. Prolonged, long runs of arrhythmia. Again, I think because you're then worrying about more significant arrhythmias or the hemodynamic effect of simply shorter breath. And sweaty, again, hemodynamic effect. The other one, classically, in SVT and atrial arrhythmia, you go into an atrially based arrhythmia. Your atrial release ANP, atrial natriuretic peptide. So often people talk about a sudden need to breathe, which I accept if you are heavily pregnant with bladder pressure can be difficult to pick up. But that suddenness, again, sometimes will give you the flavour. This is an atrial. But in terms of our investigations, so we won't have a prolonged high-level ECG session here, but probably the ECG is easy. In terms of what people without having to do very much. If they've got a normal ECG at rest, again, your level of worry. See things, ECG on the left, classical lateral pathway. So you can maybe see that there's some slurring and delta waves there, but just having a baseline ECG is useful to us. So again, coming back to ectopics, because that's a really common complaint request to us. When we do these investigations in ECGs, what are you worried about? Well, when these Holter monitors and these ECGs come back to you, we're worried about the very high burden of ectopics on the Holter. And probably in our mind, baseline for treatment is probably about 5% of the entire Holter monitor for treatment, unless it's really bothering someone. Our threshold in the normal population to do things like ablations or other procedures is probably 10 to 15% of that. But let's say the woman doesn't have that, we'll do these investigations, what do we want? So on the ECG on the left, you can see the ectopic beat is right on this person's T wave in the ECG. So you might hear the cardiologist mutter about post-coupled ectopy. These are the kind of ectopics which give you more sustained ventricular arrhythmias, because it gets right on top of that T wave in a vulnerable period. The other thing that would worry us on the ECG on the right is that you can see the nice normal narrow complexes, and you can see the ectopic beats there. There's multiple types of ectopics. The multiple types of ectopics starts to worry us about structurally based heart disease or forms of electrical cardiomyopathies. So where it's not this single focus, which is common in normal, heart's normal population, everyone's getting multifocal ectopics worry you a little bit more. So if we see these kind of ectopic based things, these are the things which on the Holters and ECGs get us a little bit more interested in their palpitations. Yeah, another bane of my life on the Holter monitor, they report as SVE runs. So SVE runs are runs of atrial ectopy. Very brief seconds of narrow complex tachycardias. I'm sure on my Holter monitor I have them. I'm sure almost everyone will have some on their Holter monitor here. SVE run, 10 beats, 12 beats, 14 beats, 10 seconds. Not worried, not interested, wouldn't rush to treat if no symptoms. If the Holter comes back to you and says, the woman has this with symptoms and this is what's upsetting her, I think reasonable to treat, but we are not worried. We would not normally treat her symptoms. And then, forgive me, because we get a reasonable amount of these in clinics, but long QTs in the QT interval, what are we measuring? Do we believe that computer related tab? Almost always no, if we're really concerned about the woman. And I've just left this here. Everyone gets the slides, do they? Afterwards. You can find on the internet, this is how we measure the QT properly. You can see from the peak of that T wave down to where it crosses the isoelectric line. That is the end of the QT. Which if you look at some of these weird long QT syndromes afterwards, sometimes measuring that can be hard. But this is how we're measuring when we're one. So you've done your 12 lead and you get this Holter, which told you how much it upsets me when we get them. You can get nowadays up to 2 or 3 weeks fairly easily in most trusts of monitoring. A lot of the time this is going off to some automated company who then send it back to your cardiology department, then give you a readout. I think the thing to take away is a little thing on the right here. Told you everything we're not worried about. We're not worried about anything nocturnal, pretty much. We're not worried about wanky back and first degree AV block. These are common things you see on people's monitors. AV block, nocturnal, short run, short pauses. These things at night, not worried about. And in somebody's palpitation investigations, I don't think any of these findings add anything for you. So, just one in terms of palpitations potentially. Things like AV block, from a symptomatic palpitation perspective, less common. could occasionally. So this is what we're talking about when we talk about vaguely mediated AV block. A faint or something. What you can see here is that gradually the sinus rate will slow. So they will get more and more bradycardic with vagal innervation, and their PR interval will go out before they finally drop a beat. From a prognostic perspective, this isn't worrying for us electrically. We wouldn't pace for this. I accept it may be fairly miserable for the woman at the time, but this not long-term worrying for us. So if we've got some symptom correlation with this, we will give advice, sitting down, hydrating better, salts, compression stockings. But this kind of palpitations, this, not worried, not going to pace for it. The other thing we can do from a palpitations monitoring perspective are these little loop recorders, which look like a very small USB stick, fairly thin, and they just get tucked under the front of the chest, under your skin. Takes about a minute to put in. Gives you continuous monitoring. It wirelessly transmits to your local cardiology department. And it has a load of automatic alerts so that the woman doesn't need to report, constantly to us. If there's anything worrying, this auto reports to us in cardiology. But they also get a little clicker or a Bluetooth thing on their phone if they've got symptoms. They can flag it and the report again comes back to us. Nowadays, some of these will last up to 6 years. So we've got a lot of monitoring that we can do for someone. I think the major reason we would use one of these is for people with syncope, where they wouldn't be able to necessarily give you symptom correlation. So, in terms of our investigations, 12-lead ECG. So when we're talking about SVTs, in terms of the description, it's often very regular palpitations, often a sudden on-off. The mechanisms of most SVTs are around your AV node, so it doesn't tend to warm up, slow down, wobble. It tends to be fairly fixed, dependent on the node properties. So they often talk about regular, on-off. These respond to vagal maneuvers, and a lot of people will have symptoms, if you ask them very carefully, since they were young. They may not be as bad, but they will certainly have them. And the classic ECG, very narrow, complex, regular, can't obviously see any P waves there. So atrial tachycardias can be less common for us, but I do see a few. These often will be more adrenergic, volume-based in terms of starting. These can be regular, irregular. I think the classical thing we hear from a clinical history perspective for these doing these kind of things is there's often a warm up, warm down. Things build, it's going to stop, it actually slows, wobbles. And often there isn't a history of this pre-pregnancy. Atrial flutter, less common than SVT, less common than AF. Again, sudden on-offs for this because of the way the circuit works. Vagal maneuvers don't help. And then we would see atrial fluttering when we're pregnancy most commonly in the context of some form of structural heart disease. I think it'd be odd or very uncommon, I should say, to see this outside of a structural problem in someone who's pregnant. I guess up to our now growth industry in EP, AF, becoming more and more of a problem for women in pregnancy, with more women with a cardiac condition, more women with cardiovascular risk factors getting pregnant later in life. Tends to be irregular, sudden on-off for most people, though it can start with a load of ectopics before it really gets going. There's a small percentage of people where this is vaguely based, so you might get that as a trigger factor in pregnancy. Often no history, but there will be some with cardiovascular risk factors or cardiovascular condition where there is a history of this before. And like I said, more common obesity, hypertension, other cardiovascular risk factors. Last one for like investigation recognition, BT, regular. Most commonly a sudden on-off. There's normally a history of this pre-pregnancy, and we normally see this in complex structural lesions or cardiomyopathy. Yeah, so probably not going to tolerate this very well. See. The only caveat to that is this kind of VT. It's VT with a left bundle type ECG, a relatively normal left bundle VT. Your thought is that this will be coming from somewhere in the right ventricular outflow tract. And this is what they call a structurally normal VT. So this is often tolerated reasonably well. Again, this one seems to respond to adrenergic stress volume. So this is one that you might see a little bit more if women have a history of it. So treatment of their palpitations. I had an old boss who used to say the only unsafe drugs in pregnancy are chemotherapy. Everything else can be used depending on your risk and reward. I think most of the time, if we're going to pick tablets, for treatment of non-worrying palpitations, it'll be a beta blocker such as bisoprolol. Things like digoxin, safe. In emergencies, adenosine, safe. It only lasts 3 seconds. So whatever it does, it's going to be out in 3 seconds. I think those are the most common ones we use. We do quite like flecainide and verapamil for RVT. There's loads of things we can use quite safely with good history and with very little bubble. Cardioversion. Cardioversion is safe. There are lots of, again, animal studies that the fetus has a much higher DFT threshold. So if a woman needs it, she's got a hemodynamically important arrhythmia, she should cardiovert. The risk of preterm labour, we think, is very small based on tiny numbers across the entire world in studies. I think before the fetus is viable, she should get on cardiovert after about 24 weeks. Suggestion to have CTG monitoring. We have monitoring and access to do. Thanks. So ablations, again, the refractory arrhythmias, we can and we will ablate. There is lots of good safety data. Obviously, we would prefer to do it postpartum because we will get it in the ear from the managers relentlessly to try and do a woman pregnant. But we can do things with zero fluoroscopy, low fluoroscopy. We've got lots of kit and mapping kit. You can do complicated cases with work out exactly where all the anatomy is reasonably easy. So if they do have a refractory arrhythmia, tell us, and we will take them and sort it. The doses in ablation, even if we don't do it, we just do our standard setup. In terms of the technologies that we have, we've got radiofrequency ablation, we've had for years. We've got cryoablation, mainly for AF and C pathways. The only one which is now the big thing in EP, pulse field ablation, we're not sure, so we just probably would do it with one of the older technologies. I guess the only thing we would do from a technical perspective, probably avoid going from the arterial side retroaortic to that. And we have ways and means that we can get everything. So similarly to EP, if a woman needs pacing, we can pace in phenomenally low doses. Pacing fairly easy, fairly quickly. Not a bother for us. If they need it, we can do it. It's not an issue. Then the only thing I was going to say is in the last couple of years, things we can do via pacing changed a lot. So some of the ECGs and some of the things you may see written in notes have changed a lot. So that can project very well. So if you look on in panel A, the classic sort of left bundle of things you would see with old style arm pacing. The first thing we now have, I guess, is His pacing, where you can try and pace to somebody's internal electrics to get it close to what it should look like. So you may start to see differing ECG patterns with ventricular pacing. It can look like it's not working because it's so narrow. And then we've moved on from His pacing now to something called left bundle area pacing, which again in the panel BC on the far right, again you see a very narrow sort of QRS and a slightly odd QR pattern in V1 that looks nothing like the old style ECGs. This is what we're aiming for. It'll look different, but this is fine. And the other thing that we, again, get a lot of phone calls about is this pacemaker working? So we know that pacing, especially pacing someone's right ventricle, is bad for them. So we desperately try to avoid it if we can. And we've got all these little algorithms now on the pacemaker to try and minimise that. Why the pacemaker will go, I'm going to count every third beat. I'm going to see if this person has any normal conduction before I do anything. So you can see on the bottom that you've got some atrial pacing with a little P wave, then a ventricular spike, natural one. So the pacemaker's gone, that's all right. This person has an underlying rhythm. I'm going to have a little check before I start pacing. So again, it paces the atrium, little P wave, but there's no ventricular activity after it. And it will allow a certain amount of these to go by before it does things. So it checks nothing happening, but then it throws in a paced beat. Say, I didn't see anything. I'm going to pace to make sure this person's safe. Then it starts counting again. So some people don't like these little algorithms, so we'll get symptoms of palpitation, but this is normal. The pacemaker, this is what we've told it to do. This is okay. But it can look upsetting on the ECG. It just requires a discussion with the pacing department to maybe say, look, through the pregnancy, this woman's getting palpitations and dizziness. Can we just go back to a normal mode after pregnancy? We can turn all this stuff back on. Just requires discussion and, what's the best thing for the woman during that pregnancy.
Any questions?
I thought it was quite interesting that how pacemakers work. That was new to me, that it's a pace all the time. But you mentioned it's bad. Why is it bad to pace all the time?
Because if you think about your normal conduction, you get the lady node inspected. You've got your AV node in the middle of the ventricular septum, atrial septum area. All your conduction goes down relatively equal from the ventricles. How they contract, stimulus to contract is relatively similar, so they contract at the same time. If I put my lead to the right ventricular apex and pace, I pace the right ventricle earlier than the left. The depolarization then comes out the right ventricular apex, back up the left ventricle to stimulate it. So my right ventricle activated first before my left, so I get this type of phenomenon, and I get electrical dysynchrony. And eventually, in an at-risk person, you could get heart failure and ventricular impairment from that. You have millions of people who it doesn't make a jot of difference to. Why for some people, why not for others? In some people, it can be bad. There's a lot of work that's gone into these algorithms to reduce that.
Hi there, I'm Kailash. I'm one of the anesthetic consultants. I would just like to reiterate that cardioversion is safe in pregnancy. I think multiple deaths have been described in embrace because of delays to cardioversion. So I think one should not be delayed. On one of your slides, it said ablation preferably postpartum. I think there are multiple reports saying that pregnant patients should be treated as a normal patient, and if the patient needs it, it should not be delayed. So yeah, I just want to reiterate those points.
I'd like to say you refer, we will ablate because the woman needs it in a refractory arrhythmia. I'm sure you know that I go to the cath lab manager and say, can I do this pregnant woman's ablation? The level of anxiety it causes, but you're all right. If they need ablating, we will and we should ablate, and we can easily.
We've had an ask for do ablation.
You got the answer to this question. How cost effective halters are, because we're all reaching for the halter monitor request on Hive.
Yeah.
But we're now moving into the realm of the patch monitors. Like, what are your thoughts? Are they worth the effort? Because we see lots of people who've done it. Halters negative, women's not got symptoms.
So in terms of cost effectiveness of making a diagnosis in pregnancy, I think it's horrific. It's not very useful, and it's a waste. I think a lot in the clinical history, it's very useful for deciding. I guess I use it fairly defensively, like this person's been referred, someone's not happy. To prove my point that we're not seeing a sustained worrying arrhythmia. I don't know how you cost benefit that. I mean, how often in clinic, all the halters we do we really pick up anything which, beyond adding 50p of bisoprolol, which we could have done anyway? It's a different. I confess I'm as much of the problem as anyone else, and that I use it for reassurance when I do anything else.
Those people who work at St Mary's, we do have a guideline about managing palpitations in obstetrics that's available on the intranet that kind of talks you through basically Reza's first slide about what to worry about in good history, when to investigate and when to refer. Because the obstetric cardiology service can't see everybody with palpitations. So it just guides you through the initial investigation, then get referred. Thank you very much. Thanks.